Good afternoon, everyone, and thank you so much for joining us today. We will begin this session in just a few minutes. Please take some time. We strongly encourage you to complete the pre-test survey that is on the screen. I will also place this link in the chat for your convenience. We will get started in just a few minutes. All right, thank you so much for joining us today. Welcome and hello. Thank you for joining us. We welcome you to the Center of Excellence for Behavioral Health in Nursing Facilities virtual education event. Today's session will cover an introduction to creating a trauma-informed culture in the post-acute and long-term care facility. My name is Michelle Wilker, and I am the technical support for today's session. We have just a few housekeeping items to discuss as we get started. All lines are muted. If you have a question during the session, please, we encourage you to place it in the chat. This session is scheduled for 30 minutes. So due to time, we may or may not be able to have a formal question and answer segment. But if you place your questions in the chat, a Center of Excellence representative will follow up with you with a response. If you haven't already, please complete the pre-test survey. You can click the link in the chat or scan the QR code to complete the survey. Next slide, please. So again, we welcome you to today's session. As we near the end of the webinar, there will be a post-test survey that we would like you to complete as well. We thank you in advance for your time and participation. Now I will give the floor to your host, Nikki Harris. Next slide, please.
Good afternoon, everyone. I am Nikki Harris, Training and Education Lead for the Center of Excellence for Behavioral Health in Nursing Facilities. And it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. And now it is my pleasure to introduce to you all today our presenter, Ms. Paige Hector.
Okay, well, hello, everyone. Afternoon, good morning, wherever you are in this country. It is my pleasure to be with you today and talk about one of the topics I'm spending a lot of my professional time working on and developing content around to be able to share with people. The introduction to creating trauma-informed culture in the post-acute and long-term care facility. We're really going to focus on one main learning objective today. Describing some key trauma-informed care terms and concepts and how they apply in the nursing home setting. So of course, this content is extensive. It could be entire workshops over many, many days. So we're going to really try to focus on some level setting concepts that I think are super important for nursing home staff to be aware of and to understand about trauma-informed care in the nursing home setting. So I generally will ask, if I was in a live session with you, what do you think about when you hear the word trauma? You know, a lot of times people associate trauma with big events like natural disasters and, of course, the pandemic. They might think about murder and torture and rape and abuse and accidents that are really traumatic. So there's a lot of different sources of trauma. Basically, anything can be experienced as traumatic. And it really depends on the individual, their life experiences, what's going on in their life at that particular time, their stage of development. So sources of trauma are, there's many, many different ways that we can be traumatized, whether it's verbal, emotional, sexual, physical abuse or assault, neglect, poverty, homelessness, attachment injuries, losses of roles, which we, of course, in nursing homes and long-term care, we see a lot of that. Bullying, shaming, discrimination, exposure to substance use, natural disasters. But I would like you to look at the last of those points there. Witnessing any of those can actually receive the impact as traumatic. So we don't actually have to experience these events directly ourselves. Witnessing these can also be experienced as trauma. One of my favorite teachers around this topic is Dr. Gabor Mate, and he has one of the quotes in his book, The Myth of Normal. He says, trauma pervades our culture from personal functioning through social relationships, parenting, education, popular culture, economics, and politics. In fact, someone without the marks of trauma would be an outlier in our society. Isn't that remarkable? someone without the marks of trauma would be an outlier in our society. That just spoke to me and stopped me when I was reading that. So I wanted to share that with you. So the trauma definition, and I want to be clear that the CMS, Centers for Medicare and Medicaid, uses this particular definition. Individual trauma results from an event, a series of events, or a set of circumstances experienced by an individual as physically or emotionally harmful, life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So golly, isn't that a really broad definition? It can be a single event, it can be a series of events, or a set of circumstances, which to me, the pandemic, we just speak about that one, it really hits all of those different ways that trauma can show up. I want to be more clear that there's also emotional and psychological trauma, which is the result of extraordinarily stressful events that shatter a sense of security and result in a sense of helplessness in a dangerous world. While they often involve a threat to life or safety, but any situation that leaves you feeling overwhelmed and isolated can result in trauma. And I want to point out that next phrase, even if it doesn't involve physical harm. So the more frightened and helpless we feel, the more likely we are to be traumatized. Those are directly related. The more frightened and helpless we feel in a situation, even if there's no physical injury, the more likely we are to be traumatized. Another poignant quotation is by Dr. Peter Levine. Trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, and untreated cause of human suffering. There's also medical trauma. So those of us working in the healthcare field, these are psychological traumas that result from medical diagnoses or interventions. And here's the really tender place that I like to call attention to. As healthcare workers, every day we go to work to help, to heal, to make things better and easier for people. And it really is so difficult for us. And that's why I use the concept of, it would bring a lot of tenderness to this, that some of the very things that we do to help with interventions and to cure and to heal may also at the same time have the impact of being traumatic for another human being. So it can be counterintuitive. And I think the pandemic was really a case in point with that so much of what we endured and our residents and patients and families endured, and all of us as staff, sometimes it was with the intent of helping, but it was also inflicting trauma at the same time. So that's a very, very difficult place, which I believe is one of the main reasons why there's so much moral injury and burnout in staff. The sources of medical trauma are extensive. So here is but a list of some of the ones that I could come up with. From receiving a new diagnosis, for example, cancer, interactions with, and I put that in quotations, the system, the healthcare system can be traumatic. Advocating for oneself, trying to find your way, getting calls back, all of that. Loud noises, falls, nightmares, IV placements, restraints, lights, sounds, odors. You guys, there's so much that happens from the acute care side into our nursing homes that can be experienced as traumatic by people. And one of the things that I believe happens is that in healthcare, we've become pretty acculturated to these sorts of things. And it may be worth us taking a step back to realize that so much about our institutional environments actually can stimulate feelings of stress and trauma for people that we are there to serve. People in the ICU, it's a huge source of trauma. What we do know, the research shows us, of course, in an ICU, more likely, they're likely to be sedated, restrained, intubated with lots of lights and noise happening. What we know is that over 80% of mechanically vented ICU patients experience delirium. We know delirium predicts PTSD. 18 to 34% of all ICU patients have PTSD. So for a moment, just think about all the people that you have in your nursing home right now that might be coming in or moving into your community in the next week. If they've had an ICU stay, their risk for trauma and PTSD goes up. Another caveat about medical trauma is that it may be suffered in silence. We are socialized to endure medical treatment, kind of just deal with it and get through it sort of mentality. So dealing with the emotional effects of care on the psyche, we in healthcare, I truly believe this, we do a really great job of asking about pain management, symptoms, what we may not do yet, but I believe and I trust that we're learning is that we tend to not ask people about fear and sadness and worry and all of the other emotions that people can face as a consequence of a medical event or an illness. So what trauma-informed care, what we're trying to do is bring these issues to light and give them voice. As we think about our older adults aging population, and I'm going to include here people living with disabilities, because sometimes these particular losses also impact them. Loss of independence, for example, losing the skill set and maybe sometimes the ability to drive, to get somewhere, to go take care of their own business and errands. Daily living skills and instrumental activities of daily living. So managing their own finances, grocery shopping, all of those things that we just kind of, I guess, take for granted day to day. Finances, death or decline, meaningful roles, health and cognition, transitioning into a long-term care setting. All of these can be associated with an experience. If it's not experienced as trauma by the person, it could be experienced as incredibly stressful, which I think that makes sense to all of us. I have a colleague of mine, excuse me, Dr. Ganzel, that she says you cannot discount things just because they're common. And so again, I think in long-term care, we become accustomed to working with a clientele, with patients and residents who are experiencing any one or all of these particular issues. So we need to be very cognizant and very aware that for that individual, that's their foray into what could be potentially experienced as very stressful and traumatic. Things that we attribute in Medicate as signs of aging may actually be signs of trauma. This was a real big eye-opener for me when I learned this a while back in my learning journey. So changes in intake, cognition, sleep, verbalization, socialization, activity, and anxiety. So whatever methods you have in your community, whether it's a stand-up or a stand-down meeting, care plan conferences, change of shift, if we could try to bring a bit more awareness when we talk about changes of condition, whatever, there's so many different ones, all of these here, if we could bring the trauma-informed care lens to that and say, could it be attributed to, and I'm going to give you some prompts on how to bring that questioning into your daily workflow and your everyday interactions with one another. One of the big things that I'm really moving towards, I'm very passionate about language and the words that we use. So I'm really trying to shift and encourage people, invite people, rather than calling things behaviors, is to call them reactions. So there are many reactions that people have in healthcare settings that contribute to challenging care situations. So I've made a list here. I have no doubt we could make this list much longer, but I think you get a flavor of what I'm trying to convey here. So all of these things that happen, so rather than calling things behaviors, which if you think about it, everything we do every day is a behavior. I'm having a behavior right now. I'm speaking with you. That's technically a behavior. But what we've done in healthcare is we've kind of linked it up with behavior is anything that's unpleasant, inappropriate. So all of this judgment energy that comes towards that word. So if we could shift that, the way that we speak about it and think about it, to reactions, and understand that all of these things here are actually coping mechanisms. That at the time that the person was enduring a traumatic experience, doing these things actually made perfect sense. It suited the situation at the time. So it's very important for us to not label these and think they're having a behavior. If we could shift our paradigm and our thinking to a trauma-informed care lens, oh, this actually might be a coping mechanism. And Dr. Mate, I really appreciated this quotation. He says that, nor are they character faults. Though they may cause us difficulty now, they began as modes of survival. So that really was a wonderful way for me to, oh my gosh, that's a very different way for me to think about when I'm with a resident or a patient or even a staff member sometimes who might be doing or saying something that I'm not enjoying. So if noticing the language there, something that we don't enjoy. Potential impacts of trauma, extensive, but here are 5 main categories. So when we've experienced a traumatic event, it can show up in our emotional regulation, cognition, relationships, perceptions, and our physical and mental health. So again, each of these is worthy of a whole workshop on its own, but generally speaking, trauma changes the way that we think and behave. Trauma changes our outlook on life. Trauma changes the way that we react and show up in our relationships, our perceptions about the world, whether it's a safe world or not. It impacts our physical health, and there's incredible amounts of research that link physical ailments, of which there are many, many, many. Basically, every review of symptom has a link to trauma, that the more trauma we experience over the course of a lifetime, the more likely that we are to experience any myriad of diseases and illnesses. Here's another helpful paradigm I'd love to share with you. So if you are on the ground, if you are at the base of the trees and you're looking up, any one of these things here, and I'm going to go way back to childhood bullying, maybe somewhere in the middle of one's life, there might be a divorce, then we have this thing called a pandemic. When you look at them as an individual event, on the ground, we only see what's in front of us, the thing that's happening in my life at the moment. When you take it above the trees, hence this line that I've drawn through all of these things, when you go above the trees, it shows the connections of the lifetime of events, that what happens to us as children, as young adults, can weave its way through our psyche and the way that we show up physiologically, our nervous system, the way our brain operates, and can show up in an event today. Isn't that phenomenal? That something happened to an 85-year-old. I just came back from an entire conference on trauma and aging, and it was really centered around Holocaust survivors. And when you think about the trauma of those individuals and those human beings, what they experienced, and then having that through their lifetime, it makes perfect sense that all of those things are connected. Trauma is cumulative and impacts a person throughout their lifetime, no matter how long ago the event occurred. Here's another way to think about trauma. A child experiences trauma and they act out in school. It makes perfect sense. For those of you who have children, who are around children, grandchildren, it makes perfect sense if a little kiddo is experiencing hunger, insecurity, or an unsafe living environment, or if they're being hurt or abused, and they go into school and they act out in whatever fashion that their little bodies and minds do. This makes, as adults looking at this, I know I have a uprising of compassion for that little guy. It's the same thing with our adults. When we've experienced trauma over a lifetime and then we act out, that coping mechanism bubbles up in the nursing home. Now it makes more sense. It's the same exact principle. So trauma at any point in one's lifetime can show up as an adult. A quotation, this is a really great article that just came out in the Journal of the American Medical Directors Association. Some nursing homes use trauma-informed practices, but are not using a trauma-informed care lens. Right there, that sentence, I can't tell you how many times I've thought of that over the last weeks since I've read that quotation. Their practices provide care that ensures safety, promote trustworthiness, transparency, and other principles promoted by the trauma-informed care lens, but they do not consider the role of trauma in behaviors. So to me, that was a really great learning point. So I'm really focusing my work now on how do we link when those coping mechanisms show up, how might they be linked to trauma, and what does that mean for the current presentation for that person in the nursing home, whether it's post-acute or whether it's long-term care. This is a worksheet you all are welcome to use to take out of this slide deck to create. I envision it as a worksheet. I envision this being part of all of your clinical discussions, stand-up downs, care plan conferences, whatever format you use. This is a delayed reaction to trauma worksheet. So again, if you look at here, you'll notice all the different categories. So possible, delayed emotional reactions, physical, cognitive, behavioral, and existential. Within each category, you will notice that there are several possibilities. So delayed emotional reactions, irritability, aggression, distress at trauma reminders, fear, all of those things that might indicate that this person might be having an emotional reaction to a traumatic event, even if they don't link them up. So it's the same, and we could go through all of these, but you'll notice that the way that this is oriented, it's either yes, no here, and then a source. So if you are working directly with the resident or patient, the source would be the individual. If the individual has advanced dementia and is not able to engage in some kind of a dialogue around you with this, perhaps it's a spouse or a child or someone else or a staff member who's really known this person over a course of a long time. So again, here's a tool that you can use to integrate and try to bring trauma-informed care lens to your work. So we don't just stop at saying that person has a behavior or they're inappropriate or they're whatever the label and judgment is, fill in the blank. Oh, let's take a little bit deeper dive. So now we're bringing that trauma-informed care lens into the work. So another really important concept with trauma-informed care work is triggers. And I have no doubt that you all have talked about or heard about triggers. So triggers are reminders of dangers or frightening things or people that have happened in the past. And I want to clarify again that the past doesn't have to be dozens of years ago. It can be something that happened before they came into your nursing home that just happened in the hospital. The person experiences the event all over again, even if the current environment is safe. And that's why it can be so puzzling and hard for staff, because here we are, we're bringing all of our caring selves to this individual, but they are having a reaction that we don't understand. We can't figure out what's going on. They may not even understand. If we put our trauma-informed care hat on and we ask the question, might it be related to, could it be a result of, could it be something that's happened, and remove ourselves as being the stimulus of something. In other words, I worry that staff somehow think that they've done something wrong or that they're to blame. But if we can take that out of the equation and look at it from the lens of, I'm curious about what might have happened, that this person might be having a coping mechanism that served them well at one point in their life. So a little bit of framing there of how we might come up to the table a little bit differently. So trauma reminders, triggers can be interpreted and this is very important. When I am being triggered by something in my environment, it could indicate that I'm feeling not safe. I cannot protect myself. I am going to die. And I added that fourth one on there recently. I don't matter. A lot of times, the environment actually could be perfectly safe, that there's no physical threat happening, but my body has been triggered in such a way that stimulates something that could go back way to being a child or at some point many, many years ago, that I received a message of be quiet, don't speak up, just be nice all the time, that I don't matter. And that's so prevalent in our society. That's where I spend a lot of my time in some work with nonviolent communication, that when we feel that we do not matter, that actually is a trauma response. Here are two key questions. So along with the delayed reaction to trauma worksheet, here's another suggestion that you could do to integrate into your daily workflow. When a person is having some kind of an experience, and I do use the word behavior in the actual question here, this is from the Crisis and Trauma Resource Institute. When a person is doing something that staff might label as a behavior, something that the person's doing that we don't enjoy hearing or seeing or being around, if we could help ask ourselves this question, how could this behavior make sense as a reaction to past trauma? Or what might this person need to avoid reliving their trauma in the future? So if we could bring those two questions to the table, that could be a very powerful way for us to go and grow our capacity to bring trauma-informed care, that lens, to the table. That we don't stop at, well, they have a behavior and then they get into the behavior charting that we all know that we do, but we can actually expand the way that we talk about it, the way that we think about it, and hopefully the way that we care plan and bring solutions to the table. Long-term care impact of trauma can be significant, and I put in parentheses for all of us, for all of us. And what I want to acknowledge here is, folks, that these are situations that take time, effort, energy, and coordination. And I guess it's kind of a call to action that we need to really be thinking about how we create staff, time for staff and space to be able to deal with these very complex situations. So we need more emphasis on the impact of trauma on behavioral and mental health care. And I just want to say the last couple of slides here, just to ground us, I don't really go into a lot, but everything I've just talked about in this first 20 minutes together is supported in FTAG 699 and trauma-informed care. So just the general statement that what we are called to do by CMS is that ensure that residents who are trauma survivors receive culturally competent trauma-informed care in accordance with standards of practice, accounting for their experiences and preferences to mitigate triggers. So what we're trying to do here is identify, and now at some point we would talk about trauma screening and how we go about doing that, but this is the general call to action of what we are being called on to do in our nursing homes. This is a process that will never end. There is no end date or stop point that we magically become transformed as a trauma-informed care organization or practitioners, nurses, social workers, medical providers, whatever our role is that we have. This is a fluid, ongoing process with no end date. And I think that's an important part of our learning here, that we don't just say, here's one person, that they're the trauma person and they will implement it across. Trauma-informed care has to infiltrate every single thing that we do, our point of care discussions, our point of care at the bedside, all the way into meetings that don't even have residents or patients with them. So this is an organizational wide. How do we begin? Here's a few things that I thought of that you could begin doing tomorrow to create or to begin that journey of creating a trauma-informed care organization. Discussing the impact of trauma, not necessarily the sources, and that really would take us into more trauma screening, that I want to really impart to you that it's not as important as what happened to the individual as how they are reacting to it now in their current presentation. So it's a shift away of just asking about the event itself to asking about how it's showing up, the impact on the person. So incorporating a trauma-informed care lens into all that we do, those two questions would be paramount. Integrating the delayed reaction to trauma worksheet. So begin talking about, and I really encourage you, involve the people in your organization who would be doing that worksheet. So making sure that that's actually trauma-informed care, collaboration and mutuality, that we don't, just kind of bring up, here's an idea I learned in a webinar, I want you to start doing it. It's more, here's something I learned, I'm super excited about it. I'm wondering what your thoughts are. How do you see that this might work or not work in our organization? So with that, we are right at time. I just want to extend my gratitude and thankfulness that you were with me for this few minutes of your day. And I don't know that we have any time, Michelle and Nikki, for questions, but I'm available.
Thank you so very much, Paige. Thank you so very much. We could not host events like this one without people like you, proficient and knowledgeable in what you do. So thank you so very much. We thank each of you for joining us today. We ask that you complete the post-test evaluation because your feedback is important to us. Our grant is sponsored by SAMHSA, and they want to hear from you as well. So please share your feedback by completing the post-test evaluation. And if you would like to request a mental health and/or substance use disorder training for your nursing facility at no cost, please visit our website to submit a request. The link is in the chat. Again, please complete the post-test evaluation. And we thank each of you for being here today. Paige, again, thank you so very much for partnering with us to bring this information to the people that we serve. So thank you so very much. We hope that all of you have a wonderful day. Thank each of you, and we hope that you have a great remainder of your day. Thank you. Bye-bye.